Hello, everyone. Thank you for joining us. Welcome to the Avexia webinar series. Our topic for today is sexual health, libido, hormones, and beyond. Today, we have the distinct pleasure of being joined by an exciting guest, Dr. Diane Mueller, who will be our presenter for this webinar. Dr. Mueller is a catalyst for holistic healthcare, with a dual doctorate in naturopathic medicine and acupuncture and oriental medicine. Author of the best-selling book, It's Not in Your Mind, she has been featured on Fox News and numerous healthcare summits and podcasts. She owns the medical clinic MyLymeDoc.com and the sex education site MyLibidoDoc.com. Without further delay, I will now turn the webinar over to Dr. Mueller.
Hello, doctors and clinicians. Welcome to this presentation from My Libido Doc, partnered with Avexia Diagnostics. I am so excited to be talking to you about this really important topic. Before we dive into libido, sexual health, hormones, and beyond, I just want to introduce myself. I'm Dr. Diane Mueller, double doctorate, board-certified sexologist. I own two different businesses. One is working with Lyme and chronic illness. The second is working with libido and sexual health. And then on top of all that, I also train doctors and clinicians around the world in functional medicine. So looking today at a very holistic view of libido and sexual health. And I'm so glad you are here. Now, I am going to make this actionable. So at the end, you will see very specific treatment things, including things like dosages for you, so that you can turn this into an actionable step in your clinical practice. And let's get started. This is a really important thing for you to realize. Surveys have shown that 70% of people want to talk to their doctor about sex and don't. Reasons for this are fear, shame, and lack of feeling like it's appropriate. So it's really common in our intake forms that we say, how is your libido? Is it low? But what is less common is that we're actually addressing this beyond oftentimes looking at things like hormones and testosterone. So people are really at a point where they are looking to talk to somebody about this, but there is something to be said about in order to help people have a proper and healthy sexual health and sexual wellness in their intimate lives, that we need to bridge that conversation for them. We need to help them understand that it's safe for them to have these conversations with us. And oftentimes, in order to do so, we need to feel comfortable talking about it ourselves. And the only way I feel like we get there is by practice. After talking about sex on hundreds of podcasts at this point, as well as presentations like this and other types of trainings I do, it has taken a long time to become incredibly comfortable with this, but it is a developed thing that you will get to as long as you take the time to actually do it. So today, we will cover hormones, hormone testing, physical root causes of low libido beyond hormones, what else is at the root beyond physical root causes. So we're going to get into the root causes. HRT, we're going to talk a little bit about HRT, and in particular, I want to talk about testing with HRT and monitoring, because there's some misunderstanding about using tests to monitor hormones, and it's a little bit nuanced about what test goes where. So we're going to talk about when to use different types of testing for analyzing your HRT therapies, and then we're going to talk about what to do when standard treatments do not work. So one of the first things to get on the same page with that I don't think is oftentimes known is like diagnostically, how are we even diagnosing somebody with low libido? So diagnostically, low libido is known as hypoactive sexual desire disorder. And in order to be diagnosed with that, in order to give somebody that diagnosis, they have to report to you that they have a low sex drive for 6 months or more. And then we can give them that proper diagnosis. You see, this is a little bit ludicrous, though, because it's circular thinking. This is what in philosophy is called circular thinking, which is when we define the thing by talking about the thing. Meaning, we're saying in order to have a diagnosis of hypoactive sexual desire disorder, aka low libido, we have to have low libido, aka hypoactive sexual desire, for 6 months. So it's not really defining around like what is like normal compared to what? There's no like baseline for normal with this. And it's in part because we don't have this well defined, like what is healthy, what is not. I can tell you that when couples are analyzed for when they are the happiest in their relationships, they are physically, sexually intimate about once a week is what we find. And the studies have shown that when couples increase beyond once a week, they might get other things out of it, but that doesn't really lead to an increase in relationship happiness. But when they decrease below once a week, that is where we see a correlation with the happiness of the relationship failing. I find this is particularly important right now, in part for those of you that have maybe seen the Harvard study that came out in 2023 that looked at what are the top reasons to not just live longer, but to live happier lives, to live better lives. Because with all the movement that we have in the longevity space, right? We're, looking at what diets work, fasting, we're looking at peptides, we're looking at so many different cool things, methylene blue, nicotine. There's so many different fun things that are coming out in the longevity space that are really talking about how to live longer. But when we actually look at how to live longer better, what the Harvard study showed was the one thing stood out from the rest, and that was the quality of our relationships, which is one of the reasons I'm so passionate about teaching you this information because with our patients, with our clients, we do want to balance all the things. We want to make sure their circulation's good. We want to make sure their thyroid is good. We want to make sure their hormones are good. We want to make sure their digestion's good, sleep, all the things, right? All the things. And it's not just, though, about living healthier. It's about also living happier and better lives. And that's something that we can really do for our patients when we bring in the conversation of sexual health and help them be happier and more intimate in their relationships. So when it comes to low libido, when it comes to low desire, there's been 3 pillars of root causes that I've been able to identify. The one pillar is all the physical stuff, and we're going to spend most of our time today talking about that, but at least we're going to spend a little bit of time talking about pillar 2 and pillar 3. We don't have time for all of that today, but I want to at least give you some information so you're aware they exist. So pillar 1 is the physical stuff. That is everything that we can, largely lab tests for. It's really talking about what is going on in that physical body that is making somebody have a healthy sex drive or not. Then we have pillar 2, which I call the personal pillar. The personal pillar is things that we also see in studies that impact intimacy, such as body image, even things like genital image, how people feel about their genitals actually has been shown to influence their sex drive. Shame, guilt, anything we're carrying there in our psyche about it. And then also in this particular pillar, is how well do we know our own body, right? Are we able to identify our turn-ons, our turn-offs, those kind of things? Do we know ourselves well enough to say, oh yeah, this is going to help move me towards desire, help move me away? For example, in work such as the work by Dr. Emily Nagoski in her book, Come As You Are, she outlines that certain things like stress that are very, very big accelerators for some people are, more commonly brakes for others. So while stress is a huge libido killer for a lot of people, it's actually an accelerator for others. So also in pillar 2 with this personal is like, how well do we know our own body and our own needs from a lifestyle perspective to say, hey, if I choose XYZ today, I'm going to be more likely to drive my libido up or down for my partner. And then in pillar 3, we have all of the interpersonal reasons. So this is how we connect. This is how we communicate, right? It's also shown in research that in normal health and normal relationships, there's 3 threats to relationships that come up anytime there's a hard conversation. So if I'm going to talk to my partner about, like we want to change around how we're spending money, or we want to repaint the house and he doesn't want to, or he didn't take the trash out and I'm feeling annoyed. If I want to talk to him about anything, there's going to be 3 threats to our relationship. Threat to me, threat to him, threat to that joint space. And that in most types of conflict, those are all going to be equal under threat. But what we see is that when we are looking at research around talking about sexual intimacy with our partner, that there's one of those three threats that is most predominant, which is the threat to myself. Meaning if I bring sexual intimacy up, that I am most interested on a subconscious level, more than a normal conversation, I have a higher tendency to protect myself, which means I tend to, and I say this I as like the universal I, because this is talking about all humans and subconscious. I'm just using myself as an example here, that in a normal conversation like this, or in a normal conversation about sex, I'm going to be so subconsciously concerned around, am I able to be providing this for my partner? What is happening if not? And I'm going to respond to conversations oftentimes, as humans do, with a natural subconscious tendency to be guarded, to feel unsafe. And so I'm going to be more in that fight or flight. So that's what is under pillar 3, is how well do we know how to talk to our partner about this? Because we also see of all the couples that are reporting to have a really healthy sex and relationship life, 92% of them talk about it. So you're seeing this communication thread run through here, right? The couples that are doing really well here are talking about it. And many people, 70%, are saying, hey, I'd love to at least be able to talk to my doctor about this, but feel like they can't. So communication is definitely a thread that runs through this. Before we move forward, I want to let you know about my newly released book called Want to Want It. And you can find that with the QR code here. You can also find it on wanttowantit.com. I wanted to give you this resource because we are going to go much further in this particular book. In this book, I'll go much further in these concepts that we're going to talk about today. So if you want to get more information, more support here, that is how you do it. Okay, so physical root causes. So these are the top ones. There's obviously more, but let's go through these one by one. So one of the things to point out around cardiovascular, so it's no surprise for most people that cardiovascular health is very related to male libido, right? The penis needs blood to get erect. And what we see, however, is a couple things. One is the penis and the lack of erection is oftentimes the first time that a man will go to his doctor to actually find out he has a cardiovascular problem. Because remember, the blood is just not about the genitals. The blood system is everywhere. If we're having a circulatory problem, it's going to come up everywhere. When I talk to functional cardiologists, this is something that comes up a lot around, some level of erectile dysfunction is actually what gets them into their office for the first time to realize there's a real cardiovascular problem. Point being, if this is coming up that it could be cardiovascular, we want to make sure that we're not just thinking about things like the little blue pill, about citrulline, arginine, which we're going to talk about later. Those are great things to do in certain scenarios, but we want to make sure we're taking a step further and we're really getting people properly tested. I'm going to talk about that in a minute. But another thing I wanted to mention under cardiovascular here is that the cardiovascular system and the health of the cardiovascular system for libido also applies to women. I know we think about hormones a lot when it comes to things like vaginal dryness. And yes, hormones are involved in that, but so is the circulatory system. We need proper circulation to help with vaginal lubrication. We also need proper circulation to help the engorgement of the tissues of the vagina as well as the vulva to actually to get engorged enough to feel good so that sex feels good. So there's many different reasons why pain with sex occurs for women, but the improper circulatory system and improper blood flow is one of them. So with hormones, I'm talking about thyroid hormone as well as our sex hormones. So that is obviously very obvious, but just to make sure that we're naming a few things, like one of the important things to realize here is the importance of estrogen for men. There have been studies on erectile dysfunction where they've looked at estrogen and they've replaced men, they've given them small, appropriate doses of hormone replacement therapy as estrogen. And what they found is that the erectile function went back to normal. It was resolved without even the use of something like testosterone. I'm not saying that testosterone is not valuable. Of course, that's the predominant hormone. But what I am saying is estrogen what the researchers have gotten, what they've theorized from these studies is that estrogen may have a level of potentizing testosterone. So it's going to make that testosterone work better. So we do want to make sure that when we're considering hormones, we really are considering the whole hormonal health: estrogen, progesterone, testosterone, thyroid, for both women and men, and that we want all of those hormones to be in balance because they do all play some level of role in our sexual health. Obviously, stress. I already mentioned that for some people, this is a situation where they will have accelerators of their libido. Other times, it is a situation where they will have that decline in their libido, those breaks. So it can go either way. Of course, we need to mention that with stress, we can get in those changes in cortisol that can then the heightened cortisol can actually suppress testosterone. The heightened cortisol can actually create more reverse T3, that reverse thyroid, and that reverse thyroid will actually block regular thyroid from working. So some of how stress can actually impact us is not only that we can sometimes feel overwhelmed and like there's so many things to do, and how can people have a libido when they're just like checking things off their list. All of that is true, but cortisol can also downregulate testosterone, can also create more of that reverse T3, that reverse thyroid, making regular T3, regular thyroid hormone, not able to do its activity at a cellular level in the same way. And when that happens, somebody can present like they are subclinically hypothyroid. And of course, if we don't have energy, our libido goes out the door. Just a note there on that reverse T3, if you're not running it or if you haven't looked at optimal ranges, most of where we see people feel the best is when their reverse T3 is less than a 10. So the range goes up to 20 to 24 depending upon the lab. Usually it's around 24 is where it's at for that top end of the range. And so somebody can come in and look very, very normal with that reverse T3 and very normal with other thyroid levels. But if they're at that 20 for a reverse T3, their regular free T3 is being blocked at that cellular level, and they might do really well with some level of thyroid supportive therapy. Of course, neurological, right? We have to have that sensation, that signal that goes to the genitals. So if there's something that is going on, like what I say, number 6 here, where we have stealth infections, where we have toxins that are leading to a level of neurological inflammation, that can potentially lead to things such as inability to maintain an erection and even pelvic pain. Another thing that's really important to mention is pelvic floor dysfunction. And one of the things I want to make sure to mention here is this pertains to men as well as women. So much of the time, we think of pelvic floor dysfunction as being a female thing. And, we're talking about Kegels, for example. Well, there's a few things with that. Like one of the problems with Kegels is most of the time we're not engaging the entire pelvic floor, which contains 14 muscles. We're only engaging some of them. So oftentimes Kegels are not done correctly. Secondly, we are always focused on the contraction. For many women, the problem with pelvic floor issues and the problem with pain here is not that these muscles are not strong enough. It's that they don't have their ability that the elasticity is gone. So they don't have that ability to relax in the same sort of way. And then if we're doing Kegels all the time, then what's happening is we're strengthening and strengthening and strengthening even more, oftentimes disproportionately because we're not using all the muscles and we're not spending enough time on relaxing. And so that can actually lead to a even tighter, a more narrow vagina that can lead to problems as well. We also see links in pelvic floor dysfunction with male arousal and in particular with erectile dysfunction. So when that pelvic floor is misaligned, right? When those muscles are too tight, when they're too loose, when we have some sort of structural alignment, that can be impeding blood flow, that can be impeding the neurological system, and that can be impeding erection. So the pelvic floor is such an area where it gets super focused on women in this very linear way, but we really want to look at the health of the pelvic floor as pertaining to both women and men. And like I said, there's many other influencers. I'm not mentioning all of them here, but here the ones I mentioned are generally some of the top ones. Okay, I wanted to show you this lab. So this is Dutch's dried urine test that you can get at Avexia. There's several good dried urine tests that you can get at Avexia. So this is just one of many. And what you can see here, and let me get my pointer. You can see here, if you've never run one of these, just you always want to be between the two yellow stars. That's the upper and lower. And what's interesting about this is a 44-year-old female. And what we see oftentimes is we see a decline in, all the hormones. This was done around day 18 or 19. And generally, we're looking most of the time to be about like midline of where the stars are as far as what is normal. But what is interesting is you can see, progesterone looks pretty good, but look at the estrogen in this particular woman. So this is very interesting, right, from the standpoint of treatment. And this is like why oftentimes people be like, oh, you always need to be on progesterone with estrogen. Well, this person, somebody had put her on progesterone. She was off of it for about a month prior to this, so it was not in her system anymore. But she was noticing that she didn't feel that great on progesterone. And a lot of women feel really great. So that's something to just note with this. Now, the other thing I wanted to make sure to point out here is, and I'm going to go around and back and forth a little bit, is then when we get into our estrogen breakdown. So you can see we have low E1, low E2, and high E3. One of the reasons why I like typing out the estrogen so much is because if we just run, say, a serum total estrogen, we might have a ton of something like E3 and not as much of something like E1, E2. And we could have a fairly normal total, but actually a dysfunctional estrogen impact on the body. So from that standpoint, we really want to make sure that we're typing these out when we have estrogen problems to get our 3 types of estrogen. E3 is going to be that one that is helping the most with things like vaginal lubrication. And then E1 and E2 being the predominant estrogen during premenopause, E1 being the predominant estrogen postmenopause. So also noteworthy with this particular patient is the breakdown of estrogen here. So in the breakdown, the first phase of the breakdown that we're looking at is this cytochrome 1A1 pathway. The first part of this breakdown is really phase 1, right? That's a cytochrome system. And so what we're looking for is to get those ratios where this 2OH is really in that 60 to 80 range. This is the safest non-proliferative estrogen. This is the most protective estrogen. And then we want much lower amounts of the 4 and 16OH. Now, what's important to mention is 16OH is highly proliferative, but some of that proliferation does allow for building bone. So we do want enough 16OH. We definitely don't want to drop below this ratio here and get so much 2H that we start sacrificing some of the 16OH in particular, because 16OH also does have a function. While it is proliferative, it is really seen with that building bone scenario. For OH, we are worried about damaging the DNA a little bit. So that is why we see the lowest percentile there. Now, also, I want to note that this part is phase 2. So this is where we're getting it through our methylation. And with that methylation, we're looking for this guy that's at 42 to be pretty close in the center. So 42 is pretty close, so the methylation activity there is not too bad. The other thing to mention here is that why you see this so low and this so low when you're saying, oh, well, these are out of range. Well, that's because the estrogen is so low, because she has really, really low estrogen. So you're not going to make as many of these metabolites because there's just not a lot of estrogen to begin with. So that's going to be normal in relationship to the estrogen, because we're saying, okay, well, how much estrogen is being broken down to go down these pathways? Well, if you don't have much estrogen, not much is going to be broken down. But we're really paying attention to is this methylation activity bar there. That's going to really help us understand the functionality of that. Okay, and then we also see here that we get information, if you haven't seen this before, DHEA is incredibly low, the DHEAS, leading to testosterone also being a little bit on the low side. And then we can see here these 2 types of testosterone. Another thing that we're seeing there is that the 5-alpha reductase activity is pretty much in the middle. So we're making about an equal amount of the stronger and weaker forms of estrogen, which is also a good thing. The way that you can look at cortisol versus cortisone, which hyperconvert into each other, is cortisone is basically like a storage form of cortisol. So what you're looking for in part is if you see the salivary cortisol levels, if you see these like really low, like let's say you see them over here, but you see the saliva cortisone level pretty high. That is not as dysfunctional as if you were to see the cortisone levels really low. Because if we're seeing really low cortisone levels, that's saying, hey, we don't even have our stores of this available, right? So if you have enough of it stored, we can actually start converting from cortisone into cortisol to repair those levels. So the three-phase model of adrenal fatigue has really been debunked in research. Like, it's not really like the adrenals don't get fatigued. But what we do have is that HPA axis dysregulation, where the hypothalamus and the pituitary, due to a receptor resistance, are not able to properly see the amount of cortisol that is in the blood, and therefore the brain is not signaling the adrenals appropriately. But if everything is working correctly, even if somebody is on a heightened stress, if they have a ton of cortisone, they will just start to convert that more into that cortisol, and they will be able to, in part, recover their stores from that. And then, of course, with this test, we get some of these organic acids as well. So we have our B12, our B6, our biotin, glutathione, as well as our gut marker that indican oftentimes is seen with things like SIBO, leaky gut, for example. And then we have markers where we can say, okay, are we properly making dopamine, breaking down dopamine? Do we have a dopamine deficiency? And then melatonin, oxidative stress. So we get some of these markers as well. Certainly if things like indican come up, for example, we do really want to look at, do we need to SIBO test? Do we need to run a stool test? Do we want to look at zonulin, antibodies to LPS, some of our other intestinal permeability markers, which aren't totally perfect, but do give us a level of indication for that. Okay, so now let's say we got all of our testing done. We see we need to put somebody on estrogen, or not in this case, but in another case, testosterone, progesterone. This person could actually be on a little bit of testosterone because it is a little bit lower than we want to have it. So that could come up. Testosterone ranges keep moving. They've moved, you might know this, but they've moved about 40% down in the past 45 years. So we really do want women and men at that upper end of that testosterone range. So what you have here for you to help you is a little information about how to retest. So for example, estrogen, if you're using the patch, serum tends to be best for dosing. Urine is used for the metabolites to say, okay, how are we breaking it down? How are those detox, processes going? And we're going to want to measure at the midpoint of the patch. So often patches are given at 2 days a week. So we are changing them every 3 to 4 days. So we're going to do it a patch is on for 3 days. The best time to test would be on day 2. So that's how we're going to want to monitor this. Now, the biggest thing to understand is for certain things like oral dosing. Oral dosing is going to have first pass metabolism by the liver. So we're going to get more ending up in the urine. So if something is dosed orally, it's going to be very difficult to measure what the cellular impact of it, because that first pass metabolism by the liver, allowing some of these hormones to be in the urine, the metabolites, before they've actually deeply impacted the cells. So that's the biggest thing. You'll see certain things like this, like, okay, progesterone transdermal, not that great, not that easy to measure symptoms. Progesterone oftentimes is given as a troche. Troche works really well. Serum's best. You give at the midpoint of dosing. Usually this means that, okay, if you're doing a troche at night, you would wind up taking a sample in the morning, for example. So that's what that means there. So with this, you do want to consider that because we have our liver involved, because there's first pass metabolism certain ways, there's not the most perfect way of monitoring this. We still do want to monitor it. We still do want to make sure we're running a Dutch, because if we're giving something like estrogen and we are sending somebody down that wrong pathway, like this person is not going to have a good situation if she doesn't use things like DIM. And I can tell you this person 6 months later, after 6 months of being on 200 milligrams of DIM a day, which works very well for most people, this has only fallen from 76.2 for that 16-OH to 60%. So it's working, but slowly. So there's likely some genetic abnormalities, possibly with things like cytochrome 1b1 or other cytochromes that are leading to problems with the process of this particular estrogen. Okay, and then the other thing to mention about hormones and retesting is we want to look at them, we want to consider them, we do want to retest to make sure we're not completely off base here. And what we're looking for is like, okay, are we completely still way too low? Are we completely way too high? But it's very important, especially for perimenopause, menopause women, and andropause for men, that we're also judging this a lot on how they feel. Right. So we don't want to spike somebody to these crazy levels, but we want to say, hey, like, where is that level where they are feeling good? And if they're feeling good, that's a good place to stop, as long as we make sure we're not at crazy high levels. So from testosterone, from an herbal perspective, here's some ideas for you as well. Now, I've seen this work very, very well before andropause. After andropause, I've seen this be supportive, but definitely nowhere close to the level of what testosterone replacement therapy can do. And this is also true for women, that pre-menopause, I've seen this be very effective. Post-menopause, I've seen it help, but not to the same level as TRT, of course. So Shilajit is a hormone you have to know about. It's going to decrease that dihydrotestosterone, so it's going to decrease that strong form of testosterone while increasing total testosterone, while increasing that cellular availability of the free, while increasing DHEA. Tongkat Ali is super important. It's going to improve insulin sensitivity, so you get the help with testosterone for that, because that lowering of testosterone can be impacted by insulin resistance. It's going to improve cortisol balance, free testosterone, all of those things. Here's some dosing for you for men versus women. Tribulus is awesome. I've had some really great results in my clinic with Tribulus for both men and women, and it's going to increase that total testosterone, as will ashwagandha. And then we do want zinc, vitamin D, and magnesium, because these are all going to support testosterone health as well. So other things, so for women, best results for supporting them is starting before 10 years post-menopause. So once that menopause hits, and that's that one day in time where they have not bled for a year, then you have, within that 10-year period of that, you definitely want to make sure you're starting them on hormones if you want to maximize their brain and circulatory system benefits from those hormones. I generally start people more in that perimenopause stage of life, because why not make menopause go a lot easier, keep their longevity and their vitality up. I also wanted to mention that I've not had quite the same luck with estrogen and progesterone herbs as with testosterone. I have seen Vitex, also known as Chase Tree, definitely help from a standpoint of regulating progesterone for women when they are pre-menopausal. Once they reach perimenopausal, and especially post-menopausal, I've not seen the same level of help with Chase Tree, aka Vitex. I've been very underwhelmed with herbs that you can read about online, like your black cohosh or your dong quai, these herbs that are supposed to help with estrogen. I've just not seen many changes with that in my patients. Of course, those are other ideas for you. You're always welcome to try, but I didn't mention there because of that. You'll see a lot of progesterone prescribed as topical, so a lot of your yam creams, for example. One of the things to understand is progesterone is an incredibly large molecule. It's a lot larger than estrogen and testosterone. So because of that, it's not going to absorb through the skin in the same way as something like estrogen and testosterone. So estrogen and testosterone tend to, for a safety perspective, be really great to give topically because, or through injections, because orally, if you take them, there is an increased risk of clotting. Progesterone is much more safe from a standpoint of that, to give from a standpoint of anything orally. And since it's not very well absorbed through the skin, we oftentimes give it as a troche. And obviously that is not fully oral. You're going to get much of that into the sublingual veins, but of course you will get some of that orally through your digestive tract as well. So the biggest thing to understand there is not that that progesterone can't be absorbed that way. Some women definitely feel the difference, but you do want to consider that it's a very big molecule. So a lot of what you're seeing online around natural progesterone may not work to really mitigate women's symptoms here because of the fact that it's a very large molecule. DHEA, one of the biggest things that I wanted to mention here that I see a lot in, especially in perimenopause, menopause women, is it leading to cystic acne. Now, typically when that happens, I've seen a pretty high DHT. So that's where we can consider Shilajit, right, in combination with it to lower that DHT as well. Circulation-wise, I wanted to make sure to mention these things, that the total cholesterol does not very well correlate with arterial changes. That if we're going to do something like a CIMT, a CAC, a CCTA, these other types of imaging, that the thing that's going to actually correlate best with seeing plaque on the arteries is going to be your apolipoprotein B or your LDL your LDL particle count, which you need that P on there. So just wanted to mention that as circulation, if you're worried about that because somebody has ED and vaginal dryness and you want to actually see what's going on with their circulatory system, making sure that if we're not moving on to the imaging like this, that we're at a minimum from a cholesterol perspective, ordering an apolipoprotein B as well as an LDL-P. Now, also just wanted to mention quickly here that citrulline is better absorbed than arginine. So you see a lot of products on the market for the vasodilation through the upregulation of nitric oxide, and arginine being a nitric oxide precursor. Now, citrulline will help as a precursor to arginine, so it will help along that pathway, but citrulline is so much better absorbed in the digestive tract than arginine. So I prefer products that are like combo products that do have some level of arginine because some will get absorbed, so you get some that doesn't need to be converted. And you also have a higher amount of citrulline. Oftentimes 3 grams or so is a good amount of that to make sure you're getting into that absorption. So we mentioned some of these pelvic floor myths already. So again, we want to make sure the muscles are actually not too tight. And oftentimes the problem is that, hey, they are too tight, and that is not that they're too loose. That we want this for men and women is also important. One of the final things I wanted to mention, and I do go over this much more in my book, is that the sexual arousal cycle is very different for men versus women. For men, desire tends to come first, and we get this kind of 4-phase model that has been taught to us by Masters and Johnson from many, many decades ago. And so in this 4-phase model, we get the excitement, the plateau, this orgasm, this resolution, and that's part of arousal. And that excitement happens after there is that desire, that mind. For women, arousal tends to happen first. It's not desire. So many women think their libido is low and they think they're not interested because they're waiting for their mind to say, hey, I'm feeling ready for sexy time. And their body actually needs to drop in first. That arousal, which is the feelings of sensation of things being good in the body, happens before the mind is interested. So a lot of times women think their libido is low and they actually just need more time with like sensual massage, like soothing things from their partner, getting into their body, letting go of the time of the day, doing meditative things in order to actually feel things in their body. And once they're more like let go of the day, then their desire can kick in. And it's not the same 4-phase model as a man. And so this is an example of this. This is from Rosemary Bassan's work, and it's just brilliant because whether that male arousal is more linear, the female arousal is much more in a circle. And you see, right, like, okay, arousal comes and then we get desire, right? So it's that arousal before desire. And there's many factors that go into the female sexual response versus this kind of linear thing by the masculine. So if fixing root causes do not work, right, we definitely want to look at all these things. Make sure you're running your urinary samples as well on this. And if that does not work, there's a couple different ways I can help you. So one is I encourage you to join my functional medicine program. I have some of the best rates on the market for helping you with that. So I encourage you to do that. And then also, if you are looking for help beyond this and you're like, oh, you just want to take care of the physical, but you know you need to have somebody that is talking to your patients, your clients about some of these other things I'm educating you about, you can become a partner affiliate of mine and make 30 to 50% off your referrals. So if you want to take care of the medicine and want me to take care of all the sexy stuff for you, I'm super happy to partner with you on that way and pay you 30 to 50% for your referrals for that as well. So there's your links for how to get more training like this, for how to go much deeper into diagnosis, testing, treatment In all of my programs, we go into very specific protocols. We talk about root causes. We talk about the testing. We talk about what to do if things don't work, and so much more. So it's very plug and play. I like giving you actionable steps along the way. So that's that link and that QR code at the top. And then at the bottom, you'll find the link in the QR code for if you want to become an affiliate partner of mine, make 30 to 50% off your referrals. You take care of the medicine. I'll take care of helping with the communication around these other two pillars, the personal and the interpersonal, to really help somebody's libido get back on track and to really help their happiness and their relationships thrive. So it's been an absolute pleasure to present to you today. I hope you will take advantage of this test from Avexia Diagnostics, and I hope I see you in all of my programs and offerings soon.
For any questions or issues, you may contact Avexia Diagnostics by email at info@avexiadiagnostics.com or by phone 5 days a week at extended hours, 8 a.m. to 8 p.m. Eastern Time at 888-852-2723. Thank you, Dr. Mueller, for this informative presentation. Thank you again for joining us for this webinar event. Until next time, from everyone at Avexia Diagnostics and mylibidodoc.com, stay healthy, stay safe, and we wish you all the best on your pathway to wellness.